Today. It does give me great honor and pleasure to be able to present to you virtually to start off this session on the role of workforce in driving health services transformation with a presentation from Rush University Medical Center here in Chicago, Illinois, United States. Now, you may notice that our title parallels the next title in this session. That was not by accident. I actually had the pleasure of meeting Dr. Dominique Allwood 2 years ago when IHF had their Congress over in Muscat, and we've kept up a conversation ever since. We both share a passion on the role of health systems in influencing community vitality and healing our future. So with that, I'm going to turn things over to Tricia Johnson, my colleague at Rush, in just a couple of minutes. But before I do that, I wanted to lay a little bit of context. First off, about Rush. Rush is kind of uniquely structured in that it's a university within a health system. It's kind of the flip of what you normally see in the United States and many countries. And the university is not itself a separate corporate entity. The university and the medical center are one and the same. We report up to the same leaders, and the leaders report up to the same governance structure. What this allows us to do is have a very tight integration between what's going on in the area of practice and what our students are learning. It's something that we sometimes refer to as a practitioner-teacher model of education. This practitioner-teacher model also extends to how we think about the role of the health system today and going into the future. You can see here on this slide a little bit of information about Rush's mission and strategic priorities. You'll see down there in the lower right-hand side, one of the four important planks of Rush's strategy is community, and the Rush system will serve as a catalyst to measurably impact each of our communities. This is not just unique to Rush. Across the United States, there's a growing recognition of the power and impact that our health systems can have if they think strategically about the resources that they have under their control. A couple statistics for you. In the United States, health spending accounts for 18% of gross domestic product. This is a number that has been growing over the years. It is rapidly approaching $1 in every 5 that is spent in our country. Secondly, healthcare and social assistance is the largest employment sector. This is both by total employees and by payroll. It accounts for 14% of all workers who are employed in the health sector. And it doesn't even take into account all of the individuals working for organizations that serve the health sector in a wide variety of ways. Add to this that we know that employment security, living wage, and a thriving wage, these are all themselves social determinants of health. Looked at through this lens, it becomes very apparent that we ought to be looking at human resource management strategically, not just in terms of the health system, but in terms of the impact that we can be having in our communities. And just to make this a bit more contextualized and more local, you can see on this slide a map of the west side of Chicago. This is the area that Rush serves most closely. The numbers you see in the yellow boxes are average life expectancies. The disparity across the west side of Chicago is about 16 years. If our best performing neighborhoods were countries, they would be among the healthiest countries in the world. If the neighborhoods that had the lowest life expectancies were countries, they would be among the most room for growth in the entire world. You can see a goal down there at the bottom. It's a pretty ambitious one. Rush is seeking to decrease life expectancy gaps in the west side of Chicago by 50% by 2030. There's a recognition on the part of Rush leadership and all involved that we are not going to achieve this goal through healthcare alone. Quality is important, but healthcare is a small slice of the impact on life expectancy. It's requiring us to think very creatively and requiring us to think about how we approach human resources management very differently. So to speak about some of the programs that Rush has going on, I turn things now over to my colleague, Tricia Johnson. Tricia?
Thank you, turn now to some examples of what healthcare organizations can do to support financial wellness for their employees. I'm going to focus on a financial well-being suite of products that we've offered our Rush employees, as well as the development of a career pathway program as one example. Here you'll see 5 different initiatives related to financial wellness that we put in place. Working credit, payroll cards for employees that don't already have checking accounts, 2 different initiatives related to student debt, and then finally, helping employees be retirement ready and saving in their 403B plan. We moved to a plan where new employees were automatically enrolled at 6% at the time of employment into the retirement plan. This initiative dramatically increased the proportion of individuals saving at least 6%, which is the percentage where they can maximize their match from the organization. Dramatically decreased the proportion who didn't save anything at all, and also decreased modestly the number of hardship applications withdrawals from the retirement plan. So this suite of packages was all designed to help individuals be more financially prepared. From a career pathway program, we piloted an initiative. We put in place an initiative in collaboration with Skills for Chicagoland's Future, the Workforce Development not-for-profit, and a community college, Malcolm X College, a healthcare sciences college right next door to Rush, to prepare individuals for nursing assistant roles. When we started the program, we had great interest over 5 cohorts. 1,800 individuals applied overall for ultimately what was 46 slots in the training program. You can see here within the training program, for those who started the pathway, almost 3/4 were certified at the end, and 26 were offered jobs at Rush. Let's talk a bit about hiring efficiency and retention, the benefits to the organization as well. On the left-hand side, you see the average days to fill PCT positions for the pathway and overall for patient care technicians at Rush. And the average days to fill was 46 overall and only 17 for the pathway, so it was much quicker to hire individuals who went through the pathway program. On the right-hand side, you also see the 90-day and 1-year retention, also significantly better, demonstrating success in keeping individuals in their jobs successfully once they were hired. So what does this mean for organizations developing career pathway programs and financial wellness programs overall? First, supporting employee financial wellness really requires a multifaceted approach. And then second, the external environment plays an important role. Healthcare organizations need to, right now, think about how the pandemic might have affected the financial wellness for their employees as well as individuals they hire on in the future, and develop strategies that will help support them to be retirement ready, particularly given that the pandemic could have had adverse consequences for savings. Second, for the patient care technician role, which is an entry-level position that can lead to future opportunities for career growth, we had huge demand. This translated into 72 applications for every 1 PCT that was ultimately hired. So there's interest in the community to get into healthcare jobs. And then third, for the pathway participants themselves, there was a high rate of completion and certification. We experienced almost 3/4 of those who were accepted into the program were ultimately certified. And that's a win for the individual as well as a win for the organization. So this just gives you a flavor of some opportunities and strategies for which healthcare organizations can support their support their employees from a financial perspective.
Hello, my name's Dominique Allwood. I'm delighted to be joining you for this session on the role of the workforce in driving health service transformation. And it's great to be here alongside a number of other speakers you'll be hearing from. I'm going to share a few slides about my presentation and we'll get underway. So this session is entitled Expanding Community Impact in the UK through Strategic Human Resource Management, similar to some other sessions in this collection, but I'm going to be talking about the NHS, our National Health Service in England and across the UK. So my name is Dominique Allwood. I'm a Senior Visiting Fellow and I work at the Health Foundation, which is a large UK-based charity and think tank. And we've been leading a lot of work around the NHS's role as an anchor institution, and I'll say a bit more about that in a moment. So about this session, you will have seen this in the description. I'm going to cover a bit about the potential for healthcare to impact on the health of its communities and citizens through the way in which it employs people. I'm going to describe a bit of our work on building healthier communities, a report that we wrote, and I'm going to show you some examples from our UK Anchor Learning Network around employment. So I guess this first slide really is just to iterate what many of you know, which is healthcare and health services make up about 10 to 20% of what makes people have good health, so access to having care. But there are many other ways in which healthcare can influence people's health, but not directly through the provision of the care that it provides, but through impacting on a number of other areas, such as working conditions and the work environment and around employment, around supporting the development of skills and people's ability to drive up their own personal wealth and finance and income. So there are many ways in which healthcare can improve health, and that's not just through direct services. And this is one of the things that is key to being an anchor institution. So the definition we work to in the Health Foundation is anchor institutions are usually large, not-for-profit organisations, unlikely to relocate and have a significant stake in the local geographical areas. So they are anchored in their surrounding communities. And they have sizable assets, and they're often the biggest employer and spender in an area. So it's about using this economic power to improve opportunities in the local area for local people. And often it's about organisations that have a social mission, like hospitals, colleges and universities, and public and municipal organisations. So very much seeing hospitals as one of these types of organisations. And the Health Foundation wrote a report in 2019 about what makes the NHS an anchor institution and identified a number of key areas that included the way in which organisations purchase and invest their resources, how they use their buildings and space, environmental impact, and how they work in partnership. But the one I'm going to be talking about just briefly is about access to quality work and the role of hospitals in doing that. So I've mentioned the fact that hospitals and healthcare organisations can really have an impact on people's health, and we know that good work is really important for health. So that includes being paid fairly and having job security, having good working conditions, a good life balance and access to training and progress in your career. And we know that our hospitals and healthcare institutions often hire and recruit a large number of people in the local place. And here's a map just across England, which shows in some places more than 10% of the local people are actually employed in the health sector. And we know in Blackpool, which is in the northwest corner of England, one of the darker patches, that 1 in 5 people in the whole of those towns and city areas is employed by the local hospital trust, the organisation. So hospitals really can have a huge impact on people's health through the way in which they employ people. And there are 3 kind of key areas that can happen. That's what through building the workforce. So how do you engage young people to think that there is a career and a possibility in the NHS? There's over 350 careers in our healthcare, and I'm sure you have a huge number in yours as well. And it's not just doctors and nurses that work in healthcare, and you don't necessarily need to have a degree. So how do you widen access and participation to careers in healthcare, and think about the types of schools and work experience you're offering those opportunities to? There's also something about widening participation of the workforce. So how do you understand the local people who might be able to get employed in your organisations, often furthest from the labour market, and sometimes might struggle to access those jobs in the way in which they're advertised or where they're recruited? And how do you offer any pre-employment support or work experience or volunteering schemes to help do that? And once those people have been employed, how do you help ensure that they have a really good, fulfilling careers in your organisation and great access to good pay, conditions, progression? For example, hospitals in our NHS have started paying the living wage and also looking at volunteer to career programmes. So I'm just going to present a few quick examples from our local and national networks that we've come across. So the first one is University Hospitals Birmingham in the centre of England. They developed a learning hub and over the last 10 years have supported over 2,500 people to get employment into their hospitals through working to develop skills and become a real hub of training and education in the local areas. So it's really important to think about that pipeline of people. Barts Health is a really large set of hospitals in northeast London, working in very diverse and deprived communities, and done huge amounts of award-winning employment programs, one being their Healthcare Horizons program, which really widens access for young people to think about joining the health service and get careers and support people to do that. And they've also been listed as one of the UK's top social mobility employers. There are only 2 hospitals in the whole of England that have that achievement, and Barts Health has been one of those, being really purposeful about training, education, apprenticeships and widening access to work. I just want to mention health and wellbeing. It comes up a lot around staff at the moment related to COVID, but also in respect of anchor institutions. And the Royal Free London did a number of engagement events to understand really who's accessing their health and wellbeing initiatives at work. And this is a large hospital in London. And they found only 10% of the lower paid staff were accessing services. So things like cycling to work schemes and yoga classes were not things that people in those jobs were able to access or found time to or found relevant. And this included people like porters, cleaners and administration staff. So they asked them, what's important to you? And they said things like, I want to be able to learn to cook with my family. I want to have a bank account. I want to have some security over my shift patterns. And I want to be able to access these types of initiatives and programs at times that suit me. Often these people are running several jobs and working in very difficult circumstances. So this organisation put a number of things in place, including cooking clubs and social events. And it had the added impact of actually reducing sickness absence in the organisation by a significant amount. So really thinking about how are you tackling the health and wellbeing of some of your lowest paid staff in your organisations. I just want to briefly mention about COVID. And I had the good fortune of being able to play my role during COVID, being medical director of one of the Nightingale hospitals in London. They had various purposes, and one was to set up hospitals, but we also ran a lot of vaccination centres, and there were big, large hubs requiring staff to be brought in and trained at very short notice. So Widen is from Wembley in London, and he's got a background in data systems and management, but has never worked in the NHS. And sadly, like many other people, he became unemployed during the pandemic and got a job as an operations manager in one of our vaccination centres. And he's now pursuing a career in the NHS. And he said things like, I'm really learning from staff and patients. They've got different skill sets to the background that I have, and I'm able to put my skills into good use that I've learned in other industries and expand my own experience and personal development. So that's been really great to open up access to people who wouldn't have worked in the NHS before. And a similar story in a way to Vicky. I was medical director at the Nightingale. She worked with me. She previously ran a homeless hostel and was employed in the Nightingale as a healthcare worker. Had never worked in healthcare before, and is now going on to complete her healthcare care certificate. So we surveyed a large number of people who worked in those temporary field hospitals and found that over 20% of them had never worked in healthcare, but 50% of them said they were likely to stay in healthcare now that they'd had that experience, and are going on to do a number of training and education programs and certificates, which is great news and really shows, I guess, how during COVID organisations can be real anchors in their community. The final example I want to tell you about is just briefly, it's a measurement example. And this is an organisation called Basildon Hospital in another part of England. And what they've done really is to say that, well, it's all very well saying you're going to put these schemes and programs on to widen access to employment or to try and employ more people locally or to target the most deprived communities. But how do you actually know you're doing that? You need to measure things. So they've plotted on a map where all their staff work and which deprivation areas they come from, things about their age, their ethnicity, all sorts of things, so they can be more purposeful about targeting gaps and areas of most need in their population for their employment and workforce initiatives. So finally, just a little plug to say that many of those examples came from people who are part of our Health Anchor Learning Network, the HALM. It's a UK-based network, but you can have a look at the resources and sign up to our newsletter. And we're often having people do talks and share interesting information about the types of things they're tackling around employment, procurement, etc., and really shows the great impact and work that our hospitals are having to improve the health of our communities. So thanks very much for listening. Please do get in touch. Here's my details if you'd like to connect. I've got a Twitter handle and an email address. And thank you very much for paying attention to this session.
Ladies and gentlemen, my name is Doris Voigt, and I'm a policy officer at the German Hospital Federation. My employer represents the entire hospital sector and is a leading actor in the German healthcare system. It's a true pleasure for me today to present on behalf of my employer a relatively new directive on systematic second opinion before an operation. First, I'll give you a quick overview on the legal framework. Then I will describe the content and purpose of the new directive, and that includes the process of second opinion and especially the duties for the physicians involved in the process. Then I will highlight the patient's strengthened role and empowerment by the directive. I also show you how and where to find the providers of a second opinion in Germany. And finally, I give you some information about the evaluation of the directive, which has already started. Obtaining a second and additional opinion is generally widely used in the German healthcare system. Interdisciplinary cooperation is common, and patients have free choice among medical specialists. The Act to strengthen the supply in the statutory health insurance of 2015 empowered patients. They became legally entitled to claim an independent second medical opinion before well-defined elective operations. On this basis, the Federal Joint Committee has developed a new directive. This is in force since December 2018 and regulates the details of a systematic second opinion for various operations with the goal to enhance the shared decision-making process. The directive of second opinion is part of the statutory healthcare provision. All physicians involved get reimbursed their costs by the insurance companies. The new directive has two parts, whereby the first part regulates the duties of all physicians involved in the second opinion process itself. The second part lists the operations and contains additional requirements on providers. In total, it specifies the patient's legal entitlement, and that's the new issue, to an independent second medical opinion. The aim is to establish a high-quality provision of a second opinion before an operation, whereby the intention behind is to avoid so-called medically unnecessary intervention. The duties of the first medical doctor starts with the indication for an operation. At that moment, the patient has to be informed about his right to obtain a second medical opinion. The information must be given verbally and in an understandable manner. And it must be given at least 10 days before a planned operation, but in any case, in sufficient time so that the patient can make a well-considered decision. Furthermore, the doctor has to hand out relevant documents to the patient if required. That includes, for example, diagnostics or laboratory results or copies of the medical record. There are formal requirements for the second opinion provider that derive from a new paragraph in the Social Code Book 5, which is the paragraph 27b. In the list of potential providers, there are physicians who participate in statutory healthcare, also physicians who are not part of the statutory healthcare but work privately. The list also includes physicians in hospitals and medical care centers, but it does not address dentists. And the second opinion may not be given by a physician who is planning to perform the operation himself. The directive requires physicians to undertake an independent physical examination of the patient, perform some further diagnostic procedures if necessary, and provide an independent medical opinion based on their own findings. The directive contains high requirements for personal medical qualifications, such as relevant specialist qualification and expertise in that specialist area, minimum of 5 years full-time professional experience, knowledge of the current state of scientific research, authorization for training medical specialists or academic teaching duties. Involved medical doctors also have to declare that they have no financial interest. The new legislation has empowered patients. Going for a second opinion is entirely voluntary. It is a free offer to all insured patients. The directive offers now various advantages to patients. They have now opportunity to get more information by more doctors. Doctors spend more time with the patient, which ultimately helps raising awareness for alternative options. By visiting the provider on the second opinion, the patient gets another physical examination, potentially further diagnostics, and an independent opinion about his medical condition. At that stage, then, the patient is informed about his various options: operation, alternative treatment, or no treatment at all. There is a general patient information sheet, which you find on the left side. It is developed specifically for the directive by the Federal Joint Committee. It explains, among other things, the second opinion procedure and shows the potential for or against an operation. This patient information leaflet also contains details about where to find more information on the internet. On the right-hand side, you see some further specific information leaflets about medical conditions leading to operations. They are developed by the Independent Institute for Quality and Efficiency in Healthcare. This institute's main task is usually to examine the benefits and harms of medical interventions for patients, and on their homepage, there's a variety of support information for patients. Both types of leaflets can be handed out by physicians to patients in paper or downloaded online comfortably at home. The second part of the directive contains the details about the operations in question. This part gets extended every time the directive applies to newly selected operations. The intervention must fulfill specific inclusion criteria, such as regional variations, high potential of complications, an established alternative treatment, or an unexplained rise in numbers. Exclusion criteria are malignant causes leading to that operation and emergency situations. This part of the directive also lists the medical specialties involved and suitable for second opinion. Today, there are 6 operations listed: tonsillectomy, hysterectomy, knee tap, shoulder arthroscopy, foot amputation in diabetic patient, and spine surgery. Based on new recommendations by our Ministry of Health, we are obliged to expand the pool of operations in the future. In due course, the focus will most likely be on cardiological interventions. Both the Association of Statutory Health Insurance Physicians and the Hospital Federations provide information on their homepages about approved physicians. The information is made freely on all platforms and requires regular updates. In the middle of the slide, I've added 2 links for you that lead to our national search engine for medical doctors. The information is prepared in such a way that patients can search for by specialists, regions, cities, or even name of a particular doctor. According to the Social Code Book 5, the results of the quality assurance measures have to be collected at the level of the federal state. The data will then be forwarded to the national state level. And finally, a report prepared on this basis will be made available to the Federal Joint Committee by September of the year following the reporting year. And this will then be published annually. The Federal Joint Committee has already started to get the directive evaluated. The aim is to get comprehensive and reliable data on the implementation of the directive and the effects on the supply structures. The crucial questions are all requirements in the directive met? Is there a need to further development of the directive? And if yes, what needs to be changed? I'd like to summarize. Without any doubt, patient sovereignty is strengthened. With the right to claim an independent second medical opinion in accordance with the Social Code Book 5, there is now fortunately an explicit legal basis that will help many patients receive a further specialist medical examination and an independent opinion before a planned operation. The new second opinion procedure set out in the directive starts, though, with a high organizational effort and bureaucracy for all physicians involved in the process. In order to achieve the goals set in the directive, the procedure must be accepted by the public, both patients and doctors. We will see. It remains also to be seen whether the application of the directive will have a practical and, above all, positive effect on doctor-patient relationship and a positive impact on the quality of care. Thank you very much for your attention.
Hi, my name is Urszula Szybowicz. I am the CEO of the Polish Hospital Federation. I wanted to tell you about a remarkable project of COVID-19 pandemic time in Poland, Hospital Health Initiative, project that we had the pleasure to co-create with scientists from the Poznan University of Economics, programmers from Klor's company, and social activities associated with the Park Foundation.
During the first wave of the COVID-19 in Poland in March 2020, there were significant deficiencies in the provision of personal protective equipment and food products to Polish hospitals. From day one, the assistance from citizens and enterprises was broad but uncoordinated and chaotic. While creating the future systems assumptions, a team of scientists and programmers determined that its crucial functionality must help hospitals report their needs, donors to declare their help, and coordinations to collect and deliver. On March 16, 2020, a key message for the project appeared on the Salesforce website. As part of the no-cost COVID-19 care response solution, working on creating a system to organize bottom-up aid was part of the task. Equally important was an acquisition and training of future system users, hospitals, coordinators, and donors. The pace of acquiring hospitals into the system was swift. Within 21 days from launching the system, 244 hospitals used it, 25% of hospitals in Poland. In the peak weeks of May, 397 hospitals and 297 nursing homes were in the system. The dynamic of registering local coordinators in the system was similar, although their verifications and training took longer than that of hospitals. 21 days after the system launch, 201 local coordinators were registered. By the end of May, this number was risen to 357 people from all over Poland. Local coordinators were crucial for the Wsparcie dla Szpitala.pl system. They were responsible for organizing collections and ongoing cooperation with the hospital or nursing home. In larger cities, such as Poznań, Gdańsk or Bydgoszcz, there were many more of them than hospitals, while in smaller towns, it was challenging to find a person ready to undertake such duty. Relationship team members often interacted with local NGOs and journalists and then collectively, using social media, encouraged the social community to take on this role. As a result of active cooperation of a small media team with journalists from mid-March to mid-May, information about the system appeared 1,393 publications, effectively reaching 7 million recipients. The graphic tool offered by Tableau software also became a beneficial tool in popularizing the system. With the support of the company employees, a team of scientists prepared a set of interactive maps and showed hospitals' needs in real time. Thanks to this solution, companies and individuals could easily understand the real needs of the health service. The created system played an important role in Poland's first wave of the pandemic, organizing and dynamizing many aid activities. Between May and June 2020, there was signals from Ukraine that they would also need a similar system. The Polish Challenge Fund, announced almost the same time, provided an excellent opportunity for this. The essence of the 6-month project implemented by the Poznań University of Economics Knowledge Transfer Company and High-Tech Office Ukraine was to gather previous experiences, train partners of the Ukrainian sides, build a local version of the system, and implement select hospitals and a group of local coordinators, accompanied by a local information campaign. 20 hospitals from 5 Ukrainian cities and leading patient organizations joined the project. Based on the local needs analysis, the Ukrainian version of the civic support system was registered and developed. Series of webinars were implemented and executed. Awareness campaign led to interest and engagement of the state's institutions, including the Ministry of Health, Ministry of Digital Transformation, and the chief state, sanitary doctor, and local business.
The experience gained from the two countries proved the legitimacy of creating an advanced platform coordinating bottom-up aid and building an ecosystem of donors, coordinators, and institutions in need of help. Such a combination organizes the helping process and makes it more effective and safer. There is a need to create an open-source solutions covering various assistance types beyond a pandemic situation and hospitals. We know how to do it, and we invite partners interested in a joint European project to contact us.